afternoon, good evening, good morning from wherever you are joining us from. My name is Colin. I'm the co-founder of Youth Initiative Development Program. Thank you for joining us this afternoon in Kenya, but I know some are dialing in from other countries. Feel welcome. We are starting as soon as possible. Good morning, good afternoon, good evening from wherever you are joining us from. My name is Collins Alandundo, Interim Chief Executive Officer and the co-founder of Youth Initiative Development Program. We are excited you have dialed in for today's exclusive and interactive roundtable. We are going to be as interactive as possible. We have a rich panel with knowledge. They are going to enjoy the session by sharing about some interesting topics that are going to be impactful and also to help us promote some of the adolescent youth sexual reproductive health and mental wellness in Africa. Next slide, please. Okay. All right. So as you can see below, the theme for today's discussion, some of the big questions that we are going to focus in is what are the sexual reproductive health disparities and injustices in Africa among the youth. Okay, so here is the housekeeping rule. Attendees will be on mute during the session. This session will be in English. We are very sorry for those who are coming from Anglophone countries. We'll ensure that our next session we do in French. And we request all the observed allocated time during the session. So our speakers, we urge you to keep time so that you can give some good time for the rest of speakers to contribute towards this topic. And the session will take 90 minutes. So around 40 minutes for interaction. So that is going to be super nice time that we can use together to interact. I'm going to take you through who Youth Initiative Development are. We are a registered nonprofit organization based in Kenya. And our aim is to inspire and empower vulnerable young people or the youth through various programs. And those areas of our programs have been stipulated there. So the intervention areas are poverty relief among the youth, sports, ICT, education, youth health and well-being, and stakeholder convening. And today's discussion is about health, reproductive health. That is something that we are much interested in. And we will make it as interactive as possible, like I said before. So here is the program for the day. So take some moment, you can take a photo or screenshot so that you familiarize with the speakers that we'll have this afternoon. Okay. All right, so I think let's move on. I'll just give some scenario. As you are all aware, we are living in a reality where millions of young people, especially the adolescents, are living in extremely difficult situation to access some of the reproductive health care in Africa. So currently there are strong commitment to ensuring that the adolescents and youth are not left behind in the context of sustainable development goals. And we really want to recommend all of you for the great work that you are doing to ensuring that the adolescents have access to reproductive health necessities, and they also have access to knowledge. But still, as we speak, we still have a lot of disparities today, a lot of gaps within the sector. We have young people who are facing, who are not in a position to access these services. And through collaboration and through partnership and through exchange program, we'll be able to come up with the tools that already been provided, or share the tools that have already been provided by WHO, and even new tools that we really find can be useful to help our youth learn about the reproductive health and also the mental wellness, or overcome maybe some of the mental scenarios that they face in the situation that they face in their daily lives. So in today's panel, we have Marie Claire, we have Maria Tori, and then we have Dr. Ben Kibirige, then we have Dr. Lioka. So we are going to introduce Marie Claire, who is the convener of Kenya Medical Association. And Marie Claire will give a brief of what Kenya Medical Association does to tackle the sexual reproductive health disparities and the situation of sexual reproductive health and mental wellness contributed to it. Over to you, Marie Claire, if you can hear me. Okay, I think Marie Claire is facing some technical problem. I'm going to invite Maria Toreri. Miss Maria Toreri is a healthcare professional with a passion for holistic well-being for adolescents and youth and responsive health systems. She has over 18 years of experience in various health programs areas, including sexual and reproductive health. Maria is an adolescent expert and a technical lead at Faith to Action Network, which is based in Nairobi. Maria Toreri, please just have a brief of what Faith to Action does and support towards accelerating advocacy, capacity building, and experience sharing. Misconception and fear of family planning, address it, and help youth understand suitable options available to avoid traditional mechanisms which are harmful. And also would like you to point out the gaps and needs for partnership with the youth communities and religious institutions, as well as private and public sector. Over to you, Maria, if you can hear me.
Thank you very much, Collins, and welcome everyone to this roundtable discussion. Yes, we are calling it roundtable, but I know we are virtual, but I welcome everybody to feel like we are all in one room. Collins, I'll request for my presentation. And it's a pleasure to be speaking to all of you. I believe that we'll have a lively session during the open forum. I think it was after the slide after this, eh?
Yes, yes.
Okay. Okay, meanwhile, I can speak about Faith to Action Network and what we do at Faith to Action Network. Faith to Action Network is a global interfaith organization that works with faith actors, both in Kenya and globally across different continents. And we focus on 3 thematic areas. These include family health and well-being, where sexual and reproductive health for adolescents and youth also lies, women's rights and gender justice, and peaceful, just and inclusive communities. The vision of Faith to Action Network, oh yeah, it's come up, eh? So maybe you can take it to the first, we start from the beginning, if you may. Okay. Yeah, thank you very much. So just scroll down because, okay, yes, so thank you very much and sorry for that hitch, our audience. So the vision of Faith to Action Network is a world where there's interfaith collaboration across all the faiths you can think of that advances healthy, inclusive, just, and peaceful communities. And that is across the thematic areas that we've talked about above. And the mission of Faith to Action Network, we mobilize and facilitate faith actors through interfaith dialogues, and we collaborate together and support the organization and organizational and capacity development. So we also amplify the voices of the faith leaders, conduct advocacy, and communicate messages for change, and also support social and behavior change. We also collect and disseminate evidence. We have projects that we implement and share our successes. And we also convene safe spaces where we can have discussions on those 3 thematic areas. So about ASRH and mental health and well-being. Yes, we are there. This is looking at the relationship between the two, between the youth SRH as well and as mental health and well-being. So we all know that a positive approach to sexuality and reproduction should recognize the part played by responsible sexual relationships, trust, and communication in the promotion of mental health and overall well-being. And then related to that, mental disorders among adolescents can have some short and long-term health and social consequences. And poor mental health during adolescence has been associated with higher substance use, early pregnancy, dropping out of school, and risky behaviors. So you can see the relationship between mental health and well-being and SRH. If one is not healthy in terms of their SRH and mentally, then it can contribute to having challenges with the other component. Then we move to the needs of the adolescents. And in that picture on your screen, you can see adolescents sharing what they would like, what they would want. They want to be healthy, they want to be happy, they want to be in charge of their lives. And how are we supporting adolescents? And the needs are diverse. We know that there are adolescents who are teen mothers, and we are not leaving the boys behind. I was told one time that even the teen fathers, as much as sometimes they're anonymous, also feel troubled. We have adolescents with disabilities, others are living with HIV, other chronic diseases, those in school, out of school, migrants and refugees. So for all these adolescents, the needs are different. What we need to do is to apply complementary strategies through various platforms, because as you can see, adolescents are to be found in many places. You'll not find them only in schools, others are out. So we need to respond to their differing needs, including contraception, and to be able to reach the unreached. We know that currently there are so many youth programs, but from my own observation, there are those who are always reached, there are those ones who are super active, the champions? What about the silent adolescent who does not know how to bring themselves to the forefront? Who does not know how to get into that room? The introvert, the poor of the poor. How do we reach these adolescents? Then we need to offer information on SRH and mental health and well-being, including where to access the services. We need to have referral systems and the services to be packaged in a way that is easily accessible to the adolescents. So we move to lessons learned from Faith to Action Network and partners. And I'll just highlight a few projects that Faith to Action Network has implemented to do with adolescent SRH. And we have SRHR advocacy in Southern Africa. The project was named Masitete, which means let's talk. So this is a project that was implemented in Eswatini, Malawi, Mozambique, South Africa, Zambia, and Zimbabwe. Then we have another one called Faith and SRHR that was implemented in West Pokot in Kenya. This one was a partnership with World Vision and DSW, for those who know the organizations. And the project was named Working Together for Children and Young Adolescents. And the aim was to create conducive environments at school, community, and faith-based spaces for promotion of SRHR. And it's important for me to mention that the first project was also in partnership with Actu Bumbano that is based in Southern Africa, as well as Bread for the World. Then another project we've implemented is named Solutions for Supporting Healthy Adolescents and Rights Protection. This is a current one. It's being implemented across 6 countries in the Great Lakes region, and they are listed there. We are promoting SRH by improving both the supply side of SRH and increasing demand for SRH services through convincing religious and sociocultural interventions. Next. So what have been the lessons learned? So the lessons that I'll be sharing are just a combination from the 3 projects I've mentioned, as well as others that I might not have mentioned, that I would like you to take away from this session, and we could also have further discussions. I know in the audience there are those who have also interacted with us or other faith-based approaches, and it will be good to share. So recognition of faith actors. As Faith to Action Network, we advocate for, and we have also learned the importance of working with faith actors. Why? The faith leaders already implement several SRH interventions within their communities and congregations. They might call them different names, but the interventions are there. So we need to strengthen them and support with adequate technical support, financial resources, and avail forums for exchanging best practices and learning from one another. Secondly, engagement and training of religious leaders. They have contributed to creating enabling environments and promoting SRHR, and also providing information for children and young adolescents. As you know, the faith leaders are also able to reach a wide population through their congregants. And from the project we did in West Pokot, the result was that many of the congregants who are part of or who got exposed to these faith leaders can freely hold SRH and other related conversations with their adolescents and the youth. Another lesson is adolescent and youth leadership. As you can see, even in this roundtable that we are in, we are having youth leading us. And when afforded the opportunity, they can be innovative and creative in their approach to addressing SRHR within the faith communities and also outside the faith communities. But the faith leaders and any other leader have to be willing to be led by young people and take time to listen to the young people's asks. And the best approach that we used was intergenerational partnership, where we also encourage the young people that you also need to listen, and there's something to learn from the older generation. There's been this slogan of nothing for us without us. And yeah, we have to remember that there's something that everyone can learn from the other. Peer learning approach has also been a very impactful model. So creating awareness and building the knowledge of adolescents and youth on SRH helped to boost their confidence, and they were able to influence their peers positively on matters SRH. And there was the added value of improved positive interactions among the peers and improved discipline. And in schools, this also led to improved academic performance. 6, multi-stakeholder approach. As I mentioned previously in this project, we partner as various partners and not just faith community alone, faith and secular partnership, interfaith partnerships between Muslims, Christians, and any other faith, and targeting diverse technical capacities. That was key in reaching adolescents, religious leaders, healthcare providers, teachers, parents, community members, who are all key players in discussing and agreeing on barriers and recommendations for increasing access to SRH information services and commodities. Number 7 is evidence-based decision-making and advocacy. So we've realized that in whatever we are doing, we cannot just talk without having necessary evidence. So we need to do research. As we're implementing, we need to learn from the beneficiaries, we need to document. And this documentation can then help policymakers and any other decision makers to utilize the findings in coming up with interventions that will be useful to the adolescents. So there's the current project that we're implementing, the one called SHARP, Solutions for Supporting Healthy Adolescents and Rights Protection. Among the studies we are doing is measuring price, availability, and affordability of SRH commodities and gaps in the supply chain, and also research on the barriers faced in accessing SRH commodities and services from the perspective of both the healthcare and the workers. So the evidence-based decision-making, programming, advocacy, I believe will help us be able to respond to the actual needs and wants of the adolescents and the youth. Then policy harmonization and implementation. What we found is that SRH policies are relatively strong in the Great Lakes region countries. Implementation remains poor, and this is often due to limited investment and low political prioritization. There is also the need for policy harmonization efforts so that we can increase the chances of having higher impact at the national levels. And the last one, which is just a bonus to encourage members of the audience, is that the faith leaders acknowledge that enhancing ASRHR has remained a major challenge within many faith institutions. I remember that at the community level, they witnessed the rampant teenage pregnancies, HIV infections, SGBV cases, and some of them have owned up to stigmatizing or discriminating against or even ignoring adolescents and young people's sexual need. But with sensitization, with trainings, empowerment, and being brought to the table, they are willing to support SRH. Then why should we work with them? The religious institutions are well placed to influence positive SRHR outcomes in many parts of Africa. They are found in most communities and they wield a lot of influence. So we are challenging policymakers, technocrats, and advocates to engage in constructive dialogue with religious leaders and faith organizations when developing policies and interventions in the regions. As Faith to Action Network, we have been able to make quite some progress with this, including in Kenya, where faith leaders are being involved in policy reviews and even developing guidelines. The language used in policies and legal texts is really different from what the faith community would consider faith-friendly. Sometimes it is misunderstood, at times it is too blunt, and therefore it might not really go far when it comes to engaging the faith community. So it is important that the presentation, packaging, content, and delivery is in a faith-friendly way that can be easily accepted and that can gain support from the faith community. So in short, there is need for sensitivity when working with the faith community and also in developing communication materials. So that's all from me. I've had to move quite fast due to the limitation of time. Thank you very much.
Thank you so much, Maria. And I really like how you brought it up. on sexuality education and how you partner with the religious institution, which is very good because there has been a misconception of sexual reproductive health is just training of how to use condoms. And like you said, sometimes language becomes so harsh in the environment. But I would really recommend and applaud for what you've done so far, because we've seen there is a lot of improved knowledge and understanding of sexual and reproductive health. And also, we've seen you going overboard and bringing some other initiative for dialogue. And also, through that, you managed to build some norms and values, and you've also promoted self-reflection among the adolescents. And I think there are a lot of people in this forum who are having questions, and I will really encourage you to post them on the chat, but we will have a forum time for open forum whereby you will be given a chance to talk. So maybe you can wait then, but we encourage you to post them on the chat, and Maria will be able to respond to them maybe on a later time. So thank you so much for that presentation. Allow me to introduce minute. Allow me to introduce Dr. Ben Kibiringe from Uganda. So Ben is a medical officer and founder and CEO for Center for Young Mothers, knowledge management champion with AMREF Health Africa, and a global co-chair for Pediatric Adolescent Virus Elimination Community Advisory Board. And Ben also is a women rights activist and gender equality advocate. So, Mr. Ben, I think right now, how serious? Like, I want to bring an issue of gender-based violence.
Okay.
How are you addressing the gender-based violence? Is it crucial in protecting sexual reproductive health and mental wellness? Please enjoy the session. Over to you.
Thank you so much, my brother Collins. It's a great honor and privilege to speak to the great experts here, our dear audience. My name is Dr. Ben Chivirige, as introduced. Very privileged to speak to you. I don't want to be tempted to go back into unpacking my toolbox, but again, I think Collins has done me justice by introducing. But what is really so dear to me are the topic that is really into discussion today: adolescent sexual reproductive health, mental wellness, and when you start speaking issues regarding SGBV in Africa, because all these programs are the cornerstone of either building or distracting our youthful generation. I must put a disclaimer that when I got this topic and the time I was allocated to speak in it, it was a little bit tight for me. And because I had a lot of things going in my head, but I'm like, let me try to, throw some little bit of points to give kind of a whole scenario to the entire discussion. Putting in mind that I'm one of the serious Pan-Africanists, and I'm someone who wants to promote African solutions that are responsive to African, populace or population and the young people. So my presentation, or what I can call that the outline of my presentation, what I want to speak about. First of all, I just want to have a glimpse of the statistics. My brother Collins has spoken about sexual gender-based violence. These problems are not new, are not alien to us. In Africa, GBV, SGBV has been one of the growing or big challenges we are having in Africa, perpetuated or caused by our societal barriers, challenges that are fueled or catalyzed by culture, the societal barriers, and all that. And obvious case from a human rights angle, patriarchy, we are in a heavily patriarchal society. So when you look at the statistics have always been staggering. But when you look at a global scale, 35% of women worldwide have experienced either physical or sexual intimate partner violence, what we can call IPV. But very serious, globally, 7% of women have been sexually assaulted by someone they know or another partner. But again, when you look at what we call murders around women that are mostly committed by their partners, and that, according to the World Bank report, gives a very whopping, value of, or total of 200 million women have experienced female genital mutilation. That comes in the bracket of the harmful practices in Africa. And again, when you continue to kind of draw a mirror or see things around mental health among the young people, these are people who are so close and dear to me, because the future, the existence of Africa, the new generations are very dependent on them. Very many studies have been published, and that's putting depression, anxiety, emotional and behavior problems, the post-traumatic stress disorders, PTSD, and suicidal thoughts being one of the key mental health challenges. And again, I'm trying to give a 360 overview of the topic, touching on mental health, SRHR, and SGBV. But again, we also know that we have a lot of mental health disorders, and it is vital that we invest in adolescent mental health now to improve the health of adolescents. We give them the best chance of health because in the different life trajectories, we need this to be prioritized so that we can lay a good foundation for a health generation of our children to follow. Now, when I give you a little bit of glimpse around sexual reproductive health, I'm a master trainer and a consultant in that field. It's also very dear to me. I want to just to throw these statistics to you so that it can trigger discussion seriously. We have over 2.2 to 4 million unsafe abortions every year among girls aged 10 to 19 in our LMICs, the low and middle income countries. Then young women account for almost 50% of annual deaths due to unsafe abortion. As a medical practitioner, I'll tell you one of the leading maternal death causes is unsafe abortion. We have hemorrhage, sepsis, and all that. And these are all manifesting from probably poorly prioritizing sexual health reproductive programs and indicators in the country. But again, worldwide, nearly half of all HIV infections and 70% of new STIs occur among the young people. The people we are proud about, the people we always boast around that Africa, 77% of our population is below the ages of 35, which is a very important thing, but again, can be a very necessary evil for your information. But looking at the barriers young people face in accessing sexual reproductive health services, obviously, we do have barriers at the health facility level, and this cuts across in whichever country in Africa those are there. Then my sister, the pre-current speakers, talked about the policies. Some of them are very discriminatory and they're not inclusive at all. So there are discriminatory laws and practices. Then very key are the societal barriers. So if at all we try to bring a discussion in that way, I think we need to tackle that. Then again, someone who has been at the forefront of advocating for what we call the demographic dividend. After having talked about the sexual reproductive health, SGBV, probably health service delivery policies, we are Africa, one of the continents in the world that has a population that is largely youthful. 77% of it, I think, is below the ages of 35. 1.2 billion young people. That is a very big number. But again, we are having a scenario that puts us at crossroads. If at all we do not utilize this population so well, that it can either affect us and actually send us very far away into a ditch, or we can utilize this population, make sure that it is empowered properly, they're very healthy, they are trained with enough skills that are marketable, and become entrepreneurs. They are given appropriate education, our health well-being, and the health is taken care of very well, including family planning, which is choice-based, and also having comprehensive access to sexual reproductive health services, commodities, and all right that. I understand very many times we shy from the word rights, but again, I'll also say if at all we put rights, governance, and youth empowerment, not forgetting a very component that is so key of meaningful youth involvement, not only meaningful youth participation, like my sister who spoke before me talked about nothing without us, nothing for us without us. So me, I'm a very good advocate for MYP, meaningful youth participation and involvement, not just representation. So we realized that in Africa, very many young people, I was reading some of the reports from WHO and the Immigration Watch, that 50% of our youthful generation by 2030 want to migrate to the Western countries. But what are the inequalities? What are the problems that are forcing these people, to say that, it's too much in Africa, it's too much in my country, let me migrate and go in another country. However harsh it is, very many people have been drowning in oceans, and they're like, no, they're at the verge of death, and they're saying, to hell with my country, with my continent, I'm not going back. So what are those things that we are not doing right as advocates, as policymakers, as elders, as religious leaders, that are forcing this young populace to exit our continent at the verge or at the expense of development or re-establishment of our continent's pride, and also development, and contributing to what we call a positive dividend. So to me, I think if at all we want to harness a very positive demographic dividend among the Africa, to see to it that the population bulge we are having that is majorly youthful is empowered, is equipped with enough technology, enough employable skills, they are accessing health and well-being in a very wonderful way. We are going to realize that these young people are going to be gold, are going to be a treasure to Africa, and we will not cry for issues like we do not have, labor, because young people will be trained. And I believe that an empowered young person, an empowered young girl, an empowered woman, an empowered man, if they have all access to these holistic programs, they will be able to, thrive and be able to harness their full potential in their youthful ages. And at the end, they will contribute to the development and growth of Africa in general. So in conclusion, because the time is really very limited, I've tried to bring kind of a broader picture and speak on different things. The simple fact is that without creating the youth bulge, the population that is, I've already talked about, of the young people, that turns into a working age bulge, there is not going to be a demographic dividend to talk about in the majority of African countries. And if at all we want to harness the demographic dividend, African countries should focus on both today and tomorrow's youth. And how are we going to do this? Make sure the health programs, because all this we are speaking is in alignment with probably the AU, the African Union Agenda 2063, then the Sustainable Development Goals, majorly with a bias on Goal 5, Goal 3, and Goal 8, because if at all we don't have enough employment for these young people, they're going to become a burden to this to Africa. They're going to become a source of insecurity. They're going to be the ones to destabilize the peace in Africa. So we need to make sure that we're having a multi-sectoral approach that is going to handle these issues, is going to see to it that the young people, the gold, the treasures we are having are taken care of. We're having programs that are responsive. But again, our entry point for harnessing the demographic dividend in most of the African countries is we need to accelerate the fact of declining the fertility, young people not producing so much. And I can give a very big, evidence regarding this medically. I understand people have various views on that and all that. Then African countries urgently need country-specific evidence and technical assistance to move the demographic agenda from rhetoric to action. We've spoken a lot. Our policymakers have spoken a lot. I always question, whenever we are on these high-level discussions, roundtables, that we have people who go and ratify on the different, documents to represent Africa's interests, and those are country-specific interests. You go and ratify probably the Maputo Protocol that specifies that 15% should be in the health budget, should be probably the budget should go to health. You go and ratify on the human rights instrument, different protocols. But again, it becomes rhetoric because we never make these things, put them into action. Then ultimately, what will make the difference is a strong political will, determination, and action to steer transformative development. If at all we continue talking when there is no political will, the countries, the different heads of state, the different countries, the different coalition bodies that are driving us, if we do not have political will and people who are determined to put whatever we're speaking into Africa, there is not going to be any kind of transformation. And to end up this, I want to say, even though our youth have the potential to transform Africa, if neglected, they could exacerbate poverty and inequality while threatening peace, security, and prosperity. Therefore, we must be proactive. I must repeat this. We must be proactive in ensuring we must meet the needs of this beginning population. I must say, and I cannot say enough, if the young people are not taken care of, if the health sector is not having programs that are responsive to the youth needs, that are responsive to the demands of the youthful generation, we are mostly to put Africa in an abyss that is going to be very hard for us to step out of it. For God and my country, for health I serve, I beg to submit for starters. Thank you.
Thank you so much, Dr. Ben. I really appreciate how you brought it out, that the GBV situations and how they are affecting the youth really need some proactiveness other than reactiveness. And I know there are a lot of questions which will come up later, maybe to see on how these can be introduced in grassroots level, whereby there are a lot of young women who are facing a lot of gender-based violence in one way or the other, and how this discussion can be even introduced to in schools, whereby young people can be versant with this knowledge, so that they know that in case of this, then that is gender-based violence. Because we have a lot of young girls, young women, and boys today who are violated and they don't know. And if in case of such a scenario, what are some of the steps that they need to take? Some are even afraid of sharing these incidences with their parents. And how can we engage, or institutions can engage with parents so that they enlighten their children, so that in case of such an incident, they'll be able to open up. And if they fear their parents, do we have some youth-friendly facilities within the communities whereby these young people who are facing this violation can go and report to? Thank you so much. And I know a lot of questions are coming up. Please don't drop out. And I'll go so quick to Lioka. I'll give a brief introduction about who he is. Lioka is a registered pharmacist and a former president of Pharmaceutical Society. He's also served as a vice chairperson of the ZAMRA Board of Directors, as well as chairperson of the Audit and Risk Committee and member of Medical Store, now ZAMSA, Board of Director. He's a trained director by the Institute of Directors. He is currently serving as an executive director of medicine research and access platform, well known as MEDRAP. So we've stated a lot of sexual reproductive health cases, and now we come to how the state of sexual reproductive health services within the universal health coverage in Africa, and how it can minimize risk of STIs, HIV, premature maternal deaths, and how to access the information among the youth, because that has become a challenge. However much youth are techno-savvy, we have some of the youth within some areas that are not able to access some useful information in sexual reproductive health, and also useful information in universal health coverage, and how they can take advantage of it, and how the role that they can play in realizing the achievement of universal health coverage. So, ladies and gentlemen, allow me to welcome Mr. Lyoka to give his thought. Over to you, Mr. Lyoka. You are on mute.
Yeah. Thank you so much, Colin. I will switch on my camera too. Are you able to share the slide, Colin?
Just a minute. We can give you a leeway to share it from your side. Is that okay?
Let me try and see if I can do that. Is it okay? Are you able to see my slide?
Yes, we can see.
Okay, thank you so much again, and good afternoon, everyone. I know that we're speaking from different jurisdictions, in Africa and maybe beyond also, and I'm happy to be part of this conversation today. I know this is a very important cross-cutting conversation, and I'm privileged to be part of this conversation with colleagues from across the region. Let me quickly go into this discussion for this afternoon. My discussion is entitled Promoting Adolescent Youth Reproductive Health and Mental Health Wellness in Africa. My name is Lyoka, and I'm the Executive Director of MEDRA. And I think, Colin, you've done more than justice to introduce me. For the sake of time, I will not go so much into that. Now, first of all, I think I just want us to look at what MEDRA is. We are an NGO registered with the Ministry of Community Development in Zambia. And we work in collaboration, especially with the line ministries, including Ministry of Health. We are a research and policy advocacy NGO, especially in the medicine supply chain system. And we do a lot of research because our advocacy is actually evidence-based, meaning that we elicit our evidence from our research work. We are called upon by, different organs of government to give expert, opinion, and they present expert papers to institutions such as the Parliament of Zambia through different committees of parliament. And we are regarded as a health think tank that promote different agendas in the health sector in Zambia. And of course, beyond, we are also active on at different regional platforms. We're talking to Faith to Action area, and I think that we are working together on the SHARP project, which I alluded to. Our mission is to strengthen health systems by promoting access to essential medicines through provision of evidence pertaining to essential medicines, especially in Zambia. And now this evidence, like I said, has to be based on research that we do, because we believe that if we do not provide evidence, then the government will be working in an information vacuum, and hence the evidence or the policies that are produced will not be able to stand the test of time. And so this policy formulation must be informed by this strong evidence. In our vision, we say that we want to have a country whose citizens enjoy equitable access to affordable, quality essential medicines at all times. And we have done implementation of different projects, in Zambia, and of course, within the sub-region, and I'm not going to talk about that. Currently, we are the implementing partner here in Zambia on the SHARP project, which my colleague Maria alluded to earlier. We are domiciled in Lusaka, which is the capital of Zambia, in an area called Ibex Hill. In case you're in Zambia, please do come through to visit us. Now, I didn't want to be assuming, and so I've just provided some basic definitions of reproductive health. And we're saying that this is a state of complete physical, mental, and social well-being, not only the absence of disease or infirmity in all matters related to reproductive health, and to its functioning and, of course, processes. I've provided different perspectives in terms of definitions of sexual reproductive health or sexual health indeed. And I think that we can take time to read through those as these presentations will actually be shared. Allow me to go into the, subject matter that we're looking at this afternoon. And I would like to look at some SRH global perspectives, and what we're trying to say is that, and I think Dr. Ben alluded to these statistics a little earlier, we have over 800 women a day that die due to complications related to pregnancy and childbirth, especially for adolescents. And annually, about 5.3 million children die before the age of 5. And half of these deaths are actually occurring in sub-Saharan Africa. In 2016, about 376 million new cases of STIs occurred. And this evidence is provided by WHO. And you can see this is quite a high statistic. Sub-Saharan Africa, ladies and gentlemen, again suffers the highest burden at global level. And we have seen that research has estimated that the lives of 4 million women, newborn and children in Sub-Saharan Africa could actually suffer per year. Could actually be saved per year, rather, if we improved interventions, such as emergency obstetric care. And I know this is common also in many African countries, that obstetric care must be improved. Breastfeeding, counseling, and treatment of infections such as diarrhea and pneumonia, which are actually, some of the leading causes of death in infants. If these are increased, then we have 90% of the families actually being saved from such, avoidable burden. Access to essential commodities and services can prevent significant proportion of death and disability. So it's actually access issues, again, that we must talk about here. However, access is currently a problem, for most, populations in Africa, and of course at global level, in the region of about 2 billion people do not have access to these, essential medicine. Okay, continuing with the state of SRH services in Africa, zeroing in Africa, we know that in the African region, we have good SRHR policies. And like other colleagues have said, our jurisdictions are actually signatory and they are party to international committees, such as the famous Maputo Plan of Action, which stipulates a number of actions, as regards sexual and reproductive health, especially for adolescents. The region's policies are relatively strong, I must say, if you look at these protocols, but implementations remains poor with adequate or dysfunctional, supply chain systems within our context, meaning that we face challenges in the implementation of universal health coverage, which reflect, a missing government ambition. Our governments are reluctant, by and large, to implementing these, policies, even though they have been ratified. For example, annually, we have about 13.9% of adolescent girls giving birth in the Great Lakes region, and they're disproportionately exposed to, a variety of sexually transmitted, illnesses, including HIV and AIDS. Our women and girls are also bear a huge burden of, sexual violence, which others have alluded to, commonly known in Zambia as GBV. And further, this actually has increased their exposure to HIV and the sexually transmitted illnesses, including issues of mental health, challenges, because these issues are also associated with stigma. And this is actually incubating a number of processes that are rendering especially our women and adolescents to suffer from many of these occurrences of mental health challenges. Complications from pregnancy, childbirth, and I'm referring to issues like postpartum hemorrhage, HIV are now the leading causes of death among women and adolescents in the African region. African governments must contribute to improve, sexual and reproductive health rights for both, women and especially adolescents to have increased access, to these services and commodities. And this can be done through improved availability, accessibility, acceptability, and equality, along with decreased social, cultural, religious, barriers. When we talk about these social, cultural, and religious barriers, these are the issues that we are dealing with, in the SHARP project, like my colleague Maria alluded to earlier. If you look at this African context, it is a highly religious context, be it Christian or Muslim or, other religious groupings that are within the context. And it means that there is a substantial, influence that is coming from our religious, orientations that tend to influence the way people access, reproductive health services. And again, if you look at Africa, it is also highly traditional and cultural in all our contexts. And these also tend to form barriers that I think we must be preparing to, counter, as a region. The Convention on the Rights of the Child, and the African chapter on the welfare and rights of the African child makes a clarion call, ladies and gentlemen, on governments to recognize the rights of the children to the enjoyment of the highest attainable standard of health, for all our contexts. And we in the SHARP project, again, consider that Africa and perhaps the Great Lakes region also is extremely faces, or rather has an extreme health inequality, socioeconomic differences, and large adolescent population. And I think Dr. Ben did allude to this large adolescent population. If you've listened to some of the vibes that are coming from the Zambian context, we have a new government that was formed only about 1.5 years ago. And this was largely driven by, the youth population that actually are drivers of change. And you can see that even when they are the drivers of change, when it comes to this, again, the recipients, of the inequality to a large extent. Traditional knowledge and attitudes, beliefs and practices also, influence our SRH. And I think I did allude to this a little earlier. And this is much compounded by poor availability of sexual and reproductive health commodities, which is driven by especially poor supply chain systems in our public healthcare delivery, systems across the African region. And then we would like to share some of the SRH core, aspects that can, I think, substantiate, change or improve the, provision of these services within our context or region. The WHO reproductive health strategy specifies 5 core aspects of SRH. And these would include improving antenatal, perinatal and postpartum and newborn care, providing high quality services to family planning, including fertility services. Eliminating unsafe abortion is very cardinal. especially for our adolescents and girls, combating STIs, HIV, reproductive tract infections. Cervical cancer is a buzzword, and other gynecological morbidities must take center stage in our approaches. And also promoting sexual health, promoting safe sexual health, especially for our women and adolescents, must take center stage in our healthcare provision systems. Now, when we talk about what must we do in order to improve the provision of sexual and reproductive health services in our African context, ladies and gentlemen, we are looking at some of the assumptions that we're using, especially in the SHARP project. And I thought that we could share some of these assumptions, and I've put them in a brief form here, which can actually elicit, wider discussions. Some of the assumptions that we want to share here that we think can improve the provision of care, in this sector is that, number one, we believe that if duty bearers adopt, develop, and strengthen and implement policies and budgets that advance SRH and essential medicines, then the provision of the services in our context is actually going to improve. So duty bearers must be targeted. And when we talk about duty bearers, we're talking about our policymakers, our healthcare providers, our local and of course central government systems, depending on our context, must be part and parcel of this discussion. Secondly, we are saying that service providers, if the service providers have quality assured SRH services and the commodities, then we know that our populations will be able to receive quality services also. So it is important again, and this discussion can take a lot of depth in looking at the training and the orientation of our service providers in providing for this kind of care. SRH is a specialized service. And so we see that in most contexts, most of the people that are providing this care may not have special training to be able to provide quality health care, especially for our adolescents again. Thirdly, we are saying that if decision makers use inclusive multi-stakeholder platforms to address SRH, this is going to lead to an improved level of service provision again. When we talk about multi-stakeholder platforms, we are referring to the public system, private sector, NGOs and civil society coming together and forming a combined voice that must advance the issue of SRH on our context. We believe that through multi-stakeholder actions, we will be able to achieve most of these outcomes that are desirable in as far as SRH is concerned. In Zambia, and I know I can also speak about Uganda and Kenya, we have a concept called Medicines Transparency Alliance, which is a multi-stakeholder platform that brings players together from the pharmaceutical sector, government, private sector, and other local players and interest groups together to discuss issues of medicines and sexual and reproductive health issues. And we know that when these groups or multi-stakeholder platforms are actually provided with evidence, they tend to have an impact in terms of policy formulation in some of these contexts. And I think we can share a number of stories that we have witnessed here in Zambia. MEDRAP being actually we are the institution that actually house this meta platform. We also believe that opinion leaders must amplify their voices, to put SRH on the public agenda. Now, again, this is an aspect where our different groups of people can come in as opinion leaders. We do have, social media today. We do have different types of media today. And when you talk about social media, I think we can talk about Facebook, Instagram, and many others, Twitter, for instance. And I've learned now that all these modes have their own preferences in different contexts. And we believe that there are people that actually tend to sway opinions. And I think that here in Zambia, what we're doing is that we are engaging these opinion leaders to be able to talk about aspects of SRH, in their different jurisdictions to their audiences, so that they can influence the agenda for SRH, in their own jurisdictions. And we believe that if we amplify their voices by giving them evidence, by educating them and capacity building them, we believe that then they can influence the thinking around their communities. They can influence the thinking around the duty bearers and the other sectors of our community to make sure that these services are actually improved. So these are some of the pillars. These are some of the assumptions that we're using. And again, this is based on mainly 4 pillars, which I've already actually talked about. And we believe that these pillars can actually help, the overall approach to SRH on the African context. And these are multi-stakeholder, approaches that we've already talked about. We are talking about amplifying voices also. We're talking about evidence-based advocacy, which must be fed by research. Because
hello, Mr. Lyoka, I'll interrupt with you a little bit. You have 1 minute remaining, please.
Thank you so much. I think this is about my last slide also. We are also talking about policy and budgetary dialogue. It is very important that civil society and the other actors that I referred to are involved in this policy dialogue, especially also to do with budgetary issues. Right now, we are going through a budgetary cycle in Zambia, and as MEDRA, we are making submissions so that we can tie in lines for advocacy towards our thematic area in terms of reproductive health. Last but not the least, we are only saying that as MEDRA, we are ready to form alliances with partners at regional level, because we believe that when we form these alliances, we will better be able to amplify our voices at both local and regional level to be able to advocate for these services for our adolescents and our women and all our populations in the region. Thank you so much, ladies and gentlemen. I rest my case at this point.
Thank you so much. Thank you so much, Mr. Lyoka. I really love how you brought it up, starting from the things that you are doing and how you are integrating it towards achieving the universal health coverage. There are a lot of questions I know which will come later, and you'll realize most of the challenges that are affecting the youth currently to achieving maybe some of the reproductive health, sexual reproductive health services is the affordability of the services within their community. And some you'll realize maybe the reachability or accessibility of the facilities which are offering these services. And this is really something which has affected the youth seriously. And remember, they have a right to sexual health, reproductive health services. And maybe if you can give a Zambia perspective, I'll start with you. And for the meantime, if you have any question, please raise your hand and I'll reach out to you. I'll give you a chance to ask any question. On the Zambian perspective, I realize even in the mental health, I think Zambia was the one which ruled a case whereby someone committed suicide and then you factored into the policy if someone died of suicide. So we have a lot of, it's called African societies seldom issues in African ways of thinking. So what is the state of the universal health coverage in Zambia, and which role are the youth playing towards realization of achieving this? Please, can you respond to this if maybe we go to the rest as well?
Thank you, Collins, for that question. I must say that in the Zambian context, we have an integration of the youths across all the regions and provinces in Zambia through the national adolescent services in the Ministry of Health. I'm privileged to have attended the meeting just a few weeks ago, where we were having a planning and review meeting for all our programming in Zambia. And our perspective, and we're looking at achievement of these goals. We're looking at the fact that the socio-economic factors have adversely affected the provision of services to our adolescents. There is a disaggregation in terms of how services are also being provided across different sectors. The main drivers and providers of health in Zambia include, of course, government, the health, the faith-based institutions, and of course the private sector. And we have done a research, Collins, and at another meeting we can share some of these outcomes. And what we have seen is that the differences in terms of the service provision across these sectors that I mentioned is actually very significant. In the public and the mission sector, these services are free, on charge basis, meaning that clients do not have to pay. But again, because of the weak supply chain systems, the availability of these commodities is nothing much to write about in terms of the public sector, especially. So much so that even if the service is provided in the public sector, our adolescents, our women do not have a choice. The method mix is very, very weak. And I think we can speak for the rest of the African region, and Zambia is not an exception to that. So these are the major drivers. And so we are forming very strong youth alliances across all the regions. And this is what the SHARP project is trying to build. And we are amplifying the voices of the youth. Like it said again, we cannot act without the adolescents. We must be able to provide that platform. And I can tell you that the youth and adolescents in Zambia, the women in Zambia, have risen to the party. We have political influences also, political will to be able to bring these services on the table. I must say that with the new government in place, I think that there is a light that begins to shine already on the Zambian context. We want to see a situation where commodities are available. We have just passed the strategic plan, the Adolescent Strategic Plan 2022 to 2026. And I think it has a lot of tie-in, messages for advocacy. We are working very closely with the Ministry of Health to make sure that we can also be party to providing technical services, in Zambia. I think that is our approach, and we are hoping that we can make the strides, going forward.
Thank you for that. I think that was elaborate. I really appreciate it, because the youth, we are not the future, like so some people may say it, but we are now. So we really need to play the greatest role in driving this. And also we really need to play the greatest role that our fellow youths enjoy the rights to sexual reproductive health services within the communities that they're coming from. And we really need to work with different stakeholders to ensuring that even our parents, because they really play the greatest role towards us, they also have some knowledge, and they also see that value of having a conversation of sexuality at a tender age. Because if we don't get it at the right time, then we might end up into a trap, because at that age is when we try to explore so many things, and at that time we are very susceptible. Adolescent age is very vulnerable, especially if by the time of exploration, and you don't know. Okay, you have a right to enjoy consented sex, yes, but you really need to know how am I doing it? Am I risking my life? And what are some of the things that I can use to protect me, not contact maybe some of the viruses or some of the diseases? I think that, thank you. I can see there is a question, and so far I don't see any hand, but I will choose random. This goes to Dr. Ben, And this was our big question. And I believe some of the presentations have responded to maybe the disparities that we have in amongst the adolescents. So Ben, so maybe what are some of the sexual reproductive health disparities in Africa as asked by Francina Koch? So maybe we will want to know some few disparities and maybe some of the innovative solutions that you really think can help us drive this. Over to you, Dr. Ben. Are you there?
All right. Thank you so much, my brother. Yes, I am there. Great. Very, very important question. Thank you so much to my previous speakers for putting things very well into context. Sexual reproductive health disparities. And I think very many barriers that are stopping young people or the youth from accessing services and making it very hard for them to access services in their full potential. First of all, I'm going to give you a slight background or a slight case and benchmarking on my country, the Pearl of Africa, Uganda. Policy-wise, we've struggled with the policy environment. You know, it's one thing that they say in Africa, we have the best policies, but never implemented. But again, we have policies that are deliberate and they are so targeted to, you know, kind of streamline how service delivery should be for reproductive health. How information is supposed to be disseminated in schools and in communities for those out of school. And for example, we do have a policy called like the sexual reproductive health policy that has been on the shelves for more than 12 years. And this is a policy that has been, you know, facing challenges or facing attacks from religious leaders, cultural leaders, saying that we bringing in religious and cultural sentiments, the fact that Uganda is a strongly religious, passively religious country, so yet may I call it a secular country. And also we have a lot of cultural rigidities that pose a very big barrier to these young people. And people always burying their heads in sand and also putting a stumbling block to the different services. Then from there, these societal issues go ahead to cause what we call an unfriendly environment that bars very many young people from accessing services. So if at all there are no policies and guidelines that are, you know, kind of streamlining how service is supposed to be given, which information, if it is age appropriate, which age, who's supposed to give it, then it simply means that even the service providers who are giving these people, it simply means they are going to find issues. Then another big animal, yes, very many of our countries always depending on donor money, donor funds, and all that. So you realize that many of the countries have not lived to what they ratified on the Maputo Protocol, whereby they say 15% of their domestic budgets or health budgets of their national budgets should be channeled to health. And realize this has caused very many problems. We do not have enough human capital in hospitals. We do not have friendly healthcare providers. We do not have medicines, because inventory is the driver of the health sector. If we go in a hospital and I write you a prescription and there is no medication, there are no sexual reproductive health commodities to give, it simply means that it's just a mere paper. So what does that mean? We need deliberate efforts, like you told me, I also give solution. We need deliberate efforts whereby we need countries to prioritize sexual reproductive health programs, service delivery, mental health services and delivery, so that we do have, first of all, human resource. We have responsive programs, responsive service delivery, and that are given by, you know, youth-friendly service providers, not being in a scenario whereby a 60-year or a 70-year-old, you know, nurse or midwife or doctor is questioning a young, you know, person, 24 years or 25, that why do you need a condom? Can't you wait? What are you trying to rush? So things like that. To me, I think if at all that is solved, it will be a very good issue. Then there is also another disparity. There is also low involvement of young people or the youth in programs that are responding to sexual reproductive health needs
of their age groups. Because I always tell people, my sister Maria spoke about nothing for us without us. I always tell young people that we should stop using that, phrase. It makes you a little bit, lazy, or it calls the opportunists to always just put you on tables without you meaningfully involving. But I just want us to have the young people empowered enough with information, because always these so-called adults or the old people tend to say that young people do not have enough skills, do not have information, they're ignorant. Even if you put them on the table, they do not have anything. So that draws in tokenism and issues, of just merely taking them to sign allowances and all that. So we need to have young people empowered and involved in priority setting, program ideation, designing, implementation, monitoring, so that we have all of them involved at all these levels. If they are peers, they will understand these programs and they know what are their relevances, so that they can go and extend these programs to their fellows and build their capacities, because there is that generational kind of attraction and there is no intergeneration gaps. Maybe lastly, what I can speak about is the infrastructure in our African setting, more so in the low and middle income countries. You realize that many people do not want to spend very many long hours in hospitals, and they wish to just go and pick a service. So with this, there are no friendly probably corners, there are no friendly spaces for young people to go and access these services. What I always encourage the Ministry of Health, and probably maybe we can learn from other colleagues from other countries, is to promote what we call integration of services. We do have what we call the kiosk models, the supermarket models. Can we have all these services centralized in one place? First, it saves resources. In terms of human capital development, in terms of human resource, you need very few people, but with vast knowledge, and we can have young people access these services in a central place, and it helps to boost demand creation and also giving adequate and appropriate knowledge to these young people. I beg to probably submit it from there. Thank you so much.
Thank you so much, Dr. Ben. That was quite elaborative. I really love how the angle that you brought it with, because youth really are very active. And sometimes if you go to a facility and you need maybe, for example, a condom, then you'll find an elderly person, and then those kind of interrogations sometimes it discourages the youth to maybe go to a facility and have them. And there is another interesting question that I am seeing here. I think this one is going to Maria. Maria, if you are still there, please respond to this. Okay, since we have adolescents and the adolescents are exposed into sexual context, do they have right to access family planning methods despite them being minors? And this question is asked by Ian Kinga. So please, through the work that you are doing, knowledge sharing within the communities and meeting the adolescent, etc., for training and advocacy, please, over to you.
Thank you very much. I'll gladly respond to that question based on, excuse me a bit. So based on my own experience working with adolescents, interaction with policy making, programming, what I would say, this has been a very touchy subject, and also my experience working with the faith community. It has been a very touchy subject, very controversial in many of the countries across Africa and beyond. And from my own perspective, this is what I would say. As you know, currently, like the trend in Kenya is sort of to avoid even discussing contraception or contraceptives for adolescents. But my personal opinion is that we should have multi-pronged approaches. As I mentioned in my presentation, adolescents are in various categories and they have different needs. We have those who are probably already married. There are those who are already teenage mothers. Others probably are undergoing violence. So we need to give services that are specific to that particular adolescent's needs. And I would talk of a multi-pronged approach. Abstinence is still very important, so we need to have sort of some primary interventions to promote abstinence. Yes, I know it's not a very popular topic or word, but we still need to promote abstinence. There are those who will not be able to abstain for various reasons. So, and some of the reasons might even be abuse that they might be undergoing through in their homes or places where we are thinking they should be safe. And that is why I think the current policy is talking about screening for the adolescents who go to seek services. I am for screening to understand the particular adolescent's need for a contraceptive method. And when we have the one-on-one with that particular adolescent, you can be able to determine why they need it. Some might be undergoing violence, which we need to open our eyes to, which would be sexual and gender-based violence or violence against children or girls and women. Yes, it's a reality, so we need to screen. And some are actually already married. Yes, we know that we're also trying to fight child marriages. But in some communities, it is a reality that there are adolescents who are already in marriage. They're already mothers. Will we deny them family planning? No. It would help to provide family planning. Then we know that family planning or contraceptives can also keep girls in school. So for a girl who already has a child or two and would like to go back to school, and probably from the one-on-one screening, we've determined that a method would help them. I would support providing a family planning method or a contraceptive to that particular adolescent. So again, this is case by case. We promote abstinence, I promote abstinence, I promote screening of an adolescent who has come for a method, of course, in an adolescent-friendly way with non-judgmental attitude, respect, confidentiality, privacy, with all the best intentions for that particular adolescent. And again, if we find that this adolescent is having other challenges that are making them come for a contraceptive method, which they believe is a solution at that time, if we've identified that it is a case of GBV or violence, SGBV, we need to refer them to a place where they can get the right services and even legal action taken against the perpetrator. So in short, it is case by case. And if we are providing adolescent-friendly or adolescent-responsive services, we can be able to do the right thing for that particular adolescent. Some of these views are very personal. They might not be related or in line with some of the policies. But yeah, I'm speaking based on my experience.
Thank you so much for bringing out that one. Sorry, we are over time, but I'm asking you, please bear with us. This is an interesting and timely discussion that will really help the lives of millions and millions of adolescents and the youth across Africa. So I think we don't have any other question, but I would like to, I can see people from Zambia, people dialing in from Tanzania, Nigeria. So maybe if I can get somebody from Zambia from Rwanda, Zambia, Mr. Halika, you are there, from Rwanda to give us a different perspective, what you are doing, how the youths are engaged in Rwanda, and maybe some of the disparities, and what have you done so far? And do you think the youth really need to come together to champion this? Because for long we've been left behind, but now we really need to put our legs together towards promoting sexual and reproductive health. Okay. All right, Miss Dorothy Timona, are you there?
Yes, hello. Yes, I'm here.
Yes, please. Maybe you can give us your verdict on the topic and maybe some of the suggestions that you really think will be helpful towards driving this. forward. Over to you.
Thank you. I appreciate the conversation on promoting adolescents, youth, sexual reproductive health. Personally, I work at the national level under the Division of Reproductive and Maternal Health in the sexual reproductive, adolescent sexual reproductive health program. My input maybe
I think we have lost you, Dorothy. Can you hear me, or am I the one facing some challenge? Or
sorry?
It's from her side. Yeah.
okay.
Oh, sorry.
Maybe
The problem is from my side.
yes. So you have some problem. We did not hear at all what your verdict on the topic. I don't know whether you can hear us now and you're in a position to contribute. All right. I think we have lost her. Maybe if I can go to another volunteer, or I'll go straight to Stephen. Stephen Daol. Stephen, can you hear me? Stephen Matthew?
Yeah. Yes, hello.
Yeah, so karibu or welcome, Stephen. Maybe if you can give us your verdict on some of the disparities that we have in sexual and reproductive health, and your opinion, how you really think we can help bridge this.
Well, can you hear me?
Loud and clear.
Yeah, I must say thank you so much for the opportunity. I'm Stephen Matthew from Rhino Camp Refugee Settlement in northern Uganda. I must say it is an interesting discussion, and I'm very glad to be part of this platform today. Based on what I've seen in Rhino Camp Refugee Settlement concerning the topic of discussion, I think much of it has been said by the speakers. In Rhino Camp, youth are really undergoing these problems of sexual reproductive health, the violence. The other thing is during the COVID, youth were at home. Most of the children were out of school, and this brought a lot of issues in the settlement. The teenage pregnancy, earlier marriages, all these things came up during COVID-19. And this really changed the scenario of the thing in Rhino Camp Refugee Settlement. And this has brought a lot of issues concerning sexual reproductive health in Rhino Camp. And most of the challenge these youth are facing are accessing the facility. In Rhino Camp, there are limited facilities because it is a remote area, and there are no many facilities for the youth to access these services. To me, I see it was the biggest challenge these youth in Rhino Camp are facing. The few health centers which are there are not having all the equipments for delivering these services. And even the health personnel are not there that could deliver these services to the youth that are available in Rhino Camp Refugee Settlement. And this has brought a lot of issues to the youth who need these services in Rhino Camp Refugee Settlement.
Thank you, Stephen, for that. We really appreciate that. And it is really, you see, like refugee camps, you really face a lot of issues, and you brought it so clearly. And I believe that through collaboration, And through this discussion, we'll be able to gain knowledge that we can use within our settlement to help the youth overcome. So I think up to that point, I'm going to go to the next agenda of today, because I can see people are dialing out because of time. But I'll give Dorothy Timona a chance. Then Dorothy will be the last person. After she is done, then we will move to the next thing. We'll have another discussion, and there is something that we really want to share with you in a moment. So please don't dial out. It is an opportunity that will really be impactful to the lives of youth. So over to you, Timona.
Hello, apologies for the disconnection earlier.
No
I hope
worries.
you can hear me now.
Loud and clear.
Yeah, so the disparities I've personally seen in our country, Kenya, I'm Dorothy from Kenya, is the issues of around culture, issues around stigma and lack of autonomy, and then there's issues around socioeconomic issues. When you go to arid and semi-arid areas, you realize that adolescents and young people in those regions are not able to access SRH services. They're not able to access things like contraceptives, they're not able to access things like sanitaries for their menstruation. So there's really a lot that needs to be done around culture, stigma, lack of autonomy, and also social economic issues. Also, my recommendation is, since we in this platform, I'm seeing we have different countries, we can look at what different countries are implementing, look at the policies and strategies for different countries. Are we speaking the same voice? Do we have the same challenges? What progress has each country made? And how can we harmonize our voices towards addressing the issues that we just discussed in the roundtable today? Thank you.
Thank you so much, Timona. I think you brought it out so clear, and that is the main purpose as to why we are having this roundtable. We really want to know, what is Uganda doing? What is Tanzania doing? What is South Africa doing? What are the gaps which are there? Or if they are the same gaps that we are facing, how did they do it? So these are the things that we really need to know, and we really need to put youth at forefront, because these are the issues that are affecting us, and we cannot keep quiet. And the only way that we can be helped is when we come out so strongly. Nobody will reach out to us at our comfort zone. So we have come out so strongly, and we really want to engage the different stakeholders to know how best can we be helped. What are the challenges we have and we experience as youth? And what are the things that we really think we can contribute towards driving these several initiatives that are geared towards improving sexual and reproductive health in Africa. So thank you for bringing out that. And that brings me to another thing. I'll hand over now to Mr. Robinson Ododa. Mr. Robinson Ododa is the project director for Youth Initiative Development Program. So Mr. Robinson Ododa, please, may you have a moment and enjoy the session.
Okay, thank you very much, Collins, and thank you the entire team. Thanks, very wonderful presentation from Maria, Dr. Ben, and Lioka. I think we've had a very insightful discussion and engagement, and from the discussions, what I'm picking up is that there is need to engage and train religious leaders, recognize the faith-based, and also there is need to have meaningful engagement with the youth, and let the youth participate and get involved in the activities that revolve around adolescents. Again, we're also picking that there's need for a multi-stakeholder approach, which is very key in terms of tackling the issues surrounding adolescents across the sub-Saharan and globally. And these are some of the issues that I think we've really gained. I know at a personal level, we've gained differently. And as Collins has said, my name is Robinson Ododa. I am an environmental and climate change expert. But again, I'm also youth. I'm also youth champion, and I'm very enthusiastic about youth activities. At YIDP, I'm the director of project and partnership. And therefore, in regard to the discussions we've had Youth Initiative Development Program has prepared a convention that is deemed to happen on 10th to 11th August from 8 a.m. to 5 a.m. East African time. The venue is at Tangaza University College. This has been done together in partnership with the III, Kenya Medical Association, Zali Foundation. So as stakeholders, as key stakeholders in the advancement of adolescents and youth activities, we are inviting you to join the convention. Register now, and can register either virtually or in person, or you can partner with us. You can join as a strategic partner, or you can partner fully with us in towards this program. For you to register, if you look at the screen, you're able to see we can get to our website and get to the convention and get to register for the upcoming convention that is due in August from 11th to from 10th to 11th, at Tangaza University. Feel welcome, and we are inviting all of you at a personal level, at organization level. If you're at organization, feel free to partner with us during the convention and probably beyond the convention activities, because the activities touching the youth and the young are continuous, and we'll keep on talking about this beyond the convention period. So once again, I'm very grateful for those who created time for this discussion. It has been a very fruitful, very engaging, and very informative. And we at YDP, we are grateful for your time, and thank you very much on behalf of YDP. Thank you very much. And at this point in time, I would say now we are at liberty to live at will. Thank you. Thank you very much.